These are my disclosures. Frailty is one of those topics that is at the same time relatively easy to understand, and that everybody knows when they see somebody who is frail. However, there are a lot of ongoing difficulties in actually describing frailty, and there's many issues that are still actively being investigated in relation to HIV. So what my objectives will be today will be to clarify a few issues regarding the biology of frailty, discuss options for diagnosing and screening for frailty, and briefly review management principles. We know that the survival of older patients living with HIV approaches that of the general population, but overall remains decreased in some elderly people to about 85–90% of the general population. And this is felt to be due to the premature development of age-related comorbidities and to the increased risk of early development of what are referred to as traditional geriatric syndromes. Now, geriatric syndromes are conditions that don't fit easily into discrete disease categories, have multifactorial etiologies, and involve multiple organ systems. Traditionally, in geriatrics, the geriatric syndromes that we recognize include polypharmacy, sensory impairment, impaired mobility and falls, cognitive impairment, impaired bowel and bladder function, and frailty, as well as recently recognized increased importance that we're giving to sarcopenia. Now, several studies have looked at traditional geriatric syndromes in people living with HIV, and these two studies basically show a similar prevalence in two distinct populations, one in San Francisco on the left from green, which basically shows that frailty was present in about 9% of individuals. Falls were present in about a quarter of people who were surveyed, and these were patients living with HIV who were well controlled with good CD4 counts and a median age of 57. Another study which looked at patients with a median age of 64, but who also had mild cognitive impairment, also showed a similar prevalence of frailty of about 70%. Falls in this analysis were reported in 40%. And for example, incontinence, another classical geriatric syndrome, was present in about 60%. And these, compared to historical controls, generally tend to be more common. Now, the underlying pathophysiology of the development of frailty is still being actively investigated, but we know that there are contributions from chronic inflammatory markers, and in the elderly, we know that chronic inflammation, immunosenescence, is common. Now, this leads to the development on its own to comorbidities and to decrease in protein synthesis, and leads to sarcopenia and wasting, and this is felt to be a prime contributor to the development of frailty. But obviously, there's a lot of work that's still being done to understand the biology of frailty. What we know more and more, and there's a lot of investigation going on here, is that there's an interaction between sarcopenia, frailty, functional limitations, and various geriatric conditions. And this is becoming an increasingly recognized and important aspect. And sarcopenia is actually now, we understand that it is more common in people living with HIV compared to controls. And it is present in about a quarter of the otherwise healthy elderly population. Now, the diagnosis of frailty is where we in geriatrics have a lot of discussion. And although this is a bit of an extreme cartoon, I think it highlights the fact that we've had quite a few consensus conferences trying to come up with a single unifying set of criteria to diagnose frailty, but we're not there yet. We're not there yet, and there's a lot of work being done. What we do have is we have several of the more very important set of criteria to operationalize frailty. And I want to go through some of these with you to better understand how to officially recognize frailty. The most common metric that's used is the frailty phenotype, initially described by Linda Fried in 2001. The other most common one that's used, and you'll see both of these if you read any articles on frailty, both in the general literature and in HIV. The Frailty Index, described by Ken Rockwood, also about 20 years ago, is the other most commonly used one. Now, unfortunately, the frailty phenotype and the frailty index do not identify the same patients. There's about a 60 to 70% overlap. We do have others, quite a lot of others, metrics that have been put forward, have been tried in a variety of populations. Some of them are actually quite easy to use, are relatively quick, but are they reliable? And some of the ones that you may come across, and some of them may actually be relevant in the clinical use in patients living with HIV, include the Clinical Frailty Scale, the simple 5-item Frail Scale, and gait speed, which may by itself be a reasonable marker for the presence of frailty, both in the general population, and increasingly evidence suggests that this may occur in HIV as well. However, what's important to note that regardless of which metric you use to diagnose frailty, what there is a consensus is that the consequences of being frail are similar. And these include multimorbidity, especially the increased risk of developing geriatric syndromes, and disability. It's important to note that frailty can be distinct from comorbidities and disabilities. Frailty also increases the risk of hospitalization, the increased risk of becoming malnourished, the loss of independence, and frailty is associated with cognitive impairment, and there is an increased risk of mortality identified in people who are diagnosed as being frail. So let me go over the criteria for the Fried frailty phenotype. And what the phenotype includes is 5 distinct parameters, each of which have very clear, objectively determined means of assessing the presence or absence. And what the consensus is that is if you have none of these parameters present, you are non-frail. Some people use the term robust. If you have 1 or 2 of them, you are considered to be pre-frail. And if you have more than 2, you are considered to be frail. In the general elderly population, the prevalence of frailty using these criteria or in patients over 65 is about 5% or so. In over 80-year-olds is about 30%. Pre-frail is much more common than frailty and occurs in about 40% of community-dwelling elderly individuals over the age of 65. I just want to point out that several of these parameters are closely associated with both sarcopenia and with depression. Now, Max cohort has done a lot of studies on frailty, and to summarize their findings, what they've shown is there's a higher prevalence in treated people living with HIV, about 12% compared to controls, and about 90% in patients and people over the age of 50. Low nadir CD4s increase the risk of frailty. Asymptomatic males who are frail and living with HIV before starting HEART are more likely to develop AIDS or to die several years after starting HEART. Now, frailty, we understand, is a dynamic process, and I'll speak a little bit about this in a few slides. But frail HIV males living with HIV are more likely to remain frail on follow-up examination than HIV-negative males who are also frail, according to these criteria. The other model, the Rockwood model, the cumulative deficit model of frailty, states that frailty is related to the age-related cumulative effects of general health deficits, and these can be either laboratory results, clinical parameters, or psychosocial aspects. The frailty severity is described using the Frailty Index, which refers to the proportions of deficits that an individual has from a non-fixed group of health variables. And these are always easily obtainable just on the basis of general history and physical and clinical examination. In community living elderly persons over 65, a frailty index of above 0.23 is generally qualifies for a diagnosis of frailty. And we understand that with the frailty index is greater than 0.7, there's a high risk of mortality. The prevalence using the frailty index in over 65-year-olds in the community is about 15%, and in over 80-year-olds is about 40%. So there are differences in the frailty between the Freed and the Rockwood models. A Canadian study recently showed that in a group of older people living with HIV with a mean age of 59, the mean frailty index was 0.33. And this was very similar to what Dr. Goraldi's group has shown in the Modena cohort, where the mean frailty index in their population was about 0.31. So we see that using the frailty index, frailty is higher in people living with HIV than in the general population. The Amsterdam cohort has also compared frailty and non-frailty using the Freed phenotype in their populations in both HIV positive and controls. And they've shown that frailty can occur at all ages over the age of 50, and it's always more common in those who are living with HIV compared to those who are not at all decades of life. A simpler frailty scale that is used, which is basically a subjective visual analog, is called a clinical frailty scale. And in this one, it has to do with how much help an individual needs to maintain an independent condition. And generally, categories 1 through 4 are considered non-frail. People are independent and they are not limited in their activities. 5, 6 are considered pre-frail, and here you need some assistance to do either instrumental activities or daily living or activities of daily living. And categories 7, 8, and 9 are considered frail, with 9 actually referring to generally describing terminally ill patients. We know that there is an association between frailty and immunosuppression, and Goraldi's group in the Modena cohort have shown that the CD4-CD8 ratio is decreased in patients who have a higher frailty index. But frailty is reversible. And the Amsterdam cohort showed that over a 2-year follow-up, and I'm just going to show the results in HIV-positive individuals, that although most people remained over the 2-year follow-up in the categories that they were initially in at intake, there was back and forth movement, and most people who were frail actually moved back towards either being pre-frail or pre-frail, moving to be robust. However, when they compared this to the HIV-negative individuals, more people with HIV moved towards frailty than in the HIV-negative controls. So what are the risk factors for progression to frailty? And various studies basically concur that older age, neurocognitive impairment, socioeconomic disadvantages, some demographics, comorbidity burdens, the initial use of an NNRTI containing antiretroviral regimen, and modifiable factors including obesity, low exercise, and smoking are risk factors for progression to frailty, whereas the use of integrase inhibitors, data shows in several studies that they may actually be protective against the development of frailty. One caveat I'd like to mention is that what we don't know are the features of aging and people living with HIV who have started on a currently recommended regimen and remained on it, and we really don't yet know if what their clinical profile will be, how often they will develop frailty, and what their overall survival will. So what can we do to screen for frailty? The frailty phenotype is used sometimes clinically, but it tends to be a little bit equipment. You need equipment and trained personnel, and takes about 10-15 minutes. The frailty index can easily be done if you have an electronic health record. Others, I've mentioned the clinical frailty scale. It's simple, it's reliable, it has been validated in diverse clinical settings, including HIV. And I would recommend that people with low CD4-CD8 ratios may also be considered for evaluation for frailty. And as I said, some studies, excuse me, do suggest that gait speed alone may be a reliable indicator of frailty. What are the recommendations for management of frail older people with HIV? Look at weight loss. What are the possible reasons for this? Address polypharmacy. Address modifiable causes of fatigue, including depression, hypothyroidism, anemia, and sustain an attempt to improve physical function, including, as I mentioned before, diagnose sarcopenia and attempt to manage it. The effectiveness of interventions in frailty are being studied. Physical activity clearly decreases the risk of becoming frail, and some suggestions are that nutritional support, either on its own or in association with physical activity, may be beneficial in preventing the development of frailty. Newer developments in management of frailty include where there's mouse models of frailty, which are being studied to understand the biology. Various drugs are actively being studied, which attempt to remove senescent cells, which are important in the development of immunosenescence and inflammation. And the actual pharmacotherapy of sarcopenia using various androgen agonists and myostatin agonists are also being investigated. Around the corner, especially in the time of COVID, is the virtual frailty assessment using various sensors and accelerometers, and there's a lot of still preliminary work being done on that. So to summarize, frailty is an important multidimensional complication often seen in older people living with HIV. It impacts clinical, functional status, quality of life, and survival. Tools to easily and reliably identify frail patients do exist, and you have a choice. And the principles of managing frailty in the general population are being adapted and are being actively investigated in people with HIV. And clearly, good evidence suggests that early and effective CART may protect against the development of frailty. Thank you very much.